So this is the underlying disease process that we're talking about, which is the atherosclerotic disease process. And at the far end of the process, so most of this is asymptomatic. So the disease, as you know, is a gradual process that the fatty build-up in the arteries that occurs gradually over many years. And mostly that is entirely asymptomatic. In fact, the lipid-laden plaques, which are the things that rupture, that trigger the blood clot, which blocks the artery, which causes the heart attack, they mostly don't cause any narrowing of the artery. So we've learned that if you actually look down many arteries and there's no narrowing of the lumen, or there's only a minor irregularity of the lumen, you will see these fatty deposits all the way down the artery. And then the thing that causes the MI is like a rupture of the fibrous cap that overlays usually in sort of 2/3 to 3/4 of the patients, it's the lipid-laden plaque, and then you've got a thin fibrous cap over the top, and then that cracks open, and that lipid is the powerful trigger for the blood clot to form, which then rapidly blocks off the artery. And that's the reason why we have very hard to, and that event is basically kind of unpredictable. So that's why you can come along to a cardiologist, have every test under the sun. We can sort of say, well, your risk is high or low, and that's what your risk is high or low, but you can't actually say, well, you're going to have a heart attack next week, or you're going to have a heart attack in whatever, because that event is kind of an unpredictable event. Now, this underlying process, but we know, so in the lipid, so the big statin trials that were done, well, the first ones that were done 20 years ago, when they looked at this, they thought, well, if we give drugs that lower the cholesterol down very low, we should get rid of the narrowings of the arteries. And so they looked at the coronary arteries on angiograms and things and found that it made absolutely no difference at all. But there was much fewer events. So the number of heart attacks went down and deaths went down, but when you looked at the arteries, the narrowings stayed exactly the same. And that's because what you do when you get rid of lower the cholesterol level over time, these lipid-laden deposits that are sort of building up gradually in the arteries, they tend to regress away. So the lower the LDL cholesterol, the lower the lipid-laden deposits. And then that provokes less inflammation in the fibrous cap that overlies the artery and separates from the blood. And that is what we call a stable situation. That's much less likely that plaque will break open and trigger the MI. So that's kind of the underlying sort of pathophysiology of the disease. So this is a cross section actually of a histology of somebody who in this case obviously died, and so this is the artery here, and this is the fibrous cap, and this is where all the lipid was, and this was the lumen of the artery, and then typically the plaque rupture happens on the edge of the plaque, and then that lipid is a very powerful stimulus for blood clot to suddenly form, and that happens abruptly and blocks the artery. So when you think of this is obviously you have to be careful about how we think the medications work, but we've got 3 types of medications in broad terms that we know reduce the risk of heart attacks and cardiovascular death and strokes. And one is the statins. So the statins are lowering the LDL cholesterol, the bad cholesterol, down to a lower level. And we know when we look at the wall of the artery by intravascular ultrasound and things, that if you're on a statin over a long period of time, those lipid-laden deposits in the wall of the artery regress away and go away. And the fibrous caps get thicker, and the probability of a rupture gets less for that reason. So that's how we think it works. And you've got to realise that that's going to take time, so it's not like a straightaway thing. So and we know that in the lipid-lowering trials, you take the statin, your cholesterol goes down, so that's what we can measure, but that benefit is actually a progressive benefit over time, so you need to stay on it for time. It's not just one day getting cholesterol down, that's not going to do it. You have to do it over a period of time, so that over time, the lipid-laden deposits gradually regress away. And we know that lifelong, if you have a lower LDL cholesterol, you will have half the risk that you would have if you were on a statin for 5 years. So there's probably a longer period of time. There is an argument that the longer on, the better. Then the next lot of treatments we have are basically blood pressure lowering treatment. So the way, in simple terms, we know blood pressure reduces the shear forces on the arteries. I mean, it has other favourable effects. To lower the blood pressure, there's less load on the heart. But in this case, in terms of the risk of triggering an event, the presumption is that you're reducing the stress forces on the wall of the arteries, which are going to be the trigger for the for this a tear to happen. So that is that. And then the third group of drugs we have are the drugs that stop the blood clotting. So for every plaque rupture that triggers a thrombus to occur that then blocks off the artery, there's probably another 10 that trigger a plaque rupture, and then the thrombus occurs, and then but it's not enough to block off the artery, and it might just heal over and just leave a narrowing, but the patients are completely fine. They don't even know about it. Or if it's in the carotid, they might have a TIA, but otherwise then be fine. So and when we see patients who have their first coronary event, and then we look at their arteries and they've got narrowings here, there, and everywhere, then they have had this event, obviously a number of occasions, obviously before, but they've just been lucky, or that has never actually gone off and blocked the artery or narrowed the artery enough to reduce the blood flow down the artery. And then in the arteries, the anticoagulants that work best are the antiplatelet drugs. So if you've got situations where blood is sitting, so that's, for example, in the left atrial appendage for stroke, that's where an atrial fibrillation, or in the veins of the leg for DVT, then blood sits, then you're better with an anticoagulant that's more effective at reducing the thrombus formation. But if you've got higher shear flow in an artery and a smaller artery, then the antiplatelet drugs are the ones that are better. Although the anticoagulants actually do reduce the risk here as well, but we tend to use the antiplatelet drugs. So the antiplatelet drugs are aspirin, clopidogrel, ticagrelor. They are the ones that are more effective at reducing the thrombus within the artery. Now the other key thing is to understand that there's this difference between stable and unstable coronary artery disease. So stable coronary artery disease is where you've got a narrowing in the artery, but it's not due to a recent plaque rupture and thrombus happening. It's due to it's a narrowing that's healed. The thrombus is all sort of organised and turned into a kind of a scar, and it's not going to cause, there's not going to be any blood clot there, but it is causing a narrowing of the artery. So that means that the artery's got a narrowing in it, and when the demands of the heart go up, like when you argue with somebody or you walk up the hill, then you'll get an increase in demand, and you'll get the symptoms of ischemia, which is tightness in the chest. But it's kind of predictable, and that actually the heart doesn't get enough blood for a while, and you get the symptoms, but it's not a risk in terms of cardiovascular events. Now that's different from unstable coronary disease, where you've got the symptoms are new. So in this case, in unstable coronary disease, you've got the plaque rupture, you've got the thrombus in the artery, but that's unstable. Anything could happen. The thrombus could form, the thrombus could dissolve away, and nothing happens, the patient gets better, or it could go on to block off the artery. Now, clinically, that's manifest as a person with something new that didn't happen before. So if every time they walk down the road and they walk up the hill and they were fine, and this morning it happened, the first time they've done it every other day, and they walk up the hill the first time it happens, that's new. That you've got to assume that's something that's happened in the arteries, and it's potentially unstable. Or they used to only get it when they walk up the hill, but now they suddenly get it at rest. They never had it rest before. That's new, that's different. So the question there is there a new plaque rupture? Is there a new narrowing? And in that situation, that can be the warning shot. So that the assumption is that it's a potentially unstable situation. That person might go, or that could be an acute coronary syndrome, or it might be a warning shot for an acute coronary syndrome. So if there's a change in the symptoms, then don't ignore it. But if it happens in a predictable, stable way, then it's not necessarily a concern. Okay, so the next thing about, I'll come back to something more, hopefully I've got the right slides, but I'll come back to something more about that. So obviously the common problem that you're faced with, and I'm faced with too, although I'm lucky in that mostly, for every 100 patients who gets chest pain, only 3 or 4 have actually had a heart attack, and maybe only 5 or 6 due to myocardial ischemia. So the problem I guess you're faced in primary care is you've got a lot of people who've got chest pain, and then what is the who's got this unstable coronary situation, and who's got a more innocent cause of the chest discomfort. And I mean, you're obviously aware of the other possible causes of chest discomfort, most of which are non-serious. So if you've got discomfort that is lasts seconds only or lasts all day, both of those things are very unlikely to be cardiac pain. If it's influenced by breathing, movement, or if you can push on it, then it's very unlikely to be cardiac pain. It's likely to be chest wall or something. But the key test that I think is very useful if in doubt, so if somebody said, oh, I got this episode of chest discomfort yesterday or 3 days ago, and they come in, they're perfectly well now, and you think, oh, well, it was like indigestion, and you think, oh, it's probably indigestion. But the key test that is very useful is a troponin, because the troponin is an incredibly sensitive measure of myocardial injury. So, and it stays around for a few days. So I think it's, if somebody's had an episode of chest discomfort in a few days, obviously you don't need to do it to everybody, but if you're, if you take the history and you examine them and you think, oh, well, I'm not really sure, then I think a troponin is a very useful test, because the troponin, so the troponin goes, it's a very sensitive, so you don't have to have very much